Welcome to the NeoFOCUS-UK Education Group webinar series.
Thanks everyone for joining the webinar today. This NeoFOCUS webinar will be given by Dr. Sherif Dabbour, who is a consultant neonatologist at St. Peter's Hospital. Thank you very much, Sherif, for joining us. We're very excited to hear your talk on tips for central catheter line tips. Sherif is an enthusiast in the use of POCUS in a clinical setting, and he's the director of efficient use of POCUS in the NICU course. Thank you, Sherif, for joining us. We're looking forward to your talk. Feel free to start your session.
Thank you very much, Jean and Sada, for this kind introduction. It's such a great honor and pleasure to have a talk on this wonderful platform. I hope that the lecture will be interesting for you. So my talk today will be about the POCUS tips for central catheter tips. And the main thing is about the reflection of on our own practice here at St. Peter's and the learning points we got from using POCUS to identify the central catheter tips. In our unit, over the last 3 years, we were heavily depending on POCUS, not only in lung ultrasound, but also to identify the central catheter tips. And we have shown that we have reduced the X-ray using for central line tips by about 73% over the last 3 years by using POCUS. In this talk, I will be going through some basics information that I'm sure that most of the people are aware of, and then I will go through 4 interesting cases, and I will feedback about the learning points from them. So generally speaking, we are using different probes to identify the central catheter tips. We are using the hockey stick probe mainly for central catheter tips that were used in both upper limbs in preterm babies, but we still can use the longer linear probes for this group of babies as well. But we use the long ones mainly for the more term babies or toward the nearly the term babies. Also, any catheter, any probe could be used to identify the central catheter tips, such as a cardiac probe, curvilinear and linear probe with lower limbs, long lines, UVC and UAC as well. So as I mentioned, I will go through the basic informations before going to the cases. So here on the right side, when a long line is inserted, for example, in the left arm, we are expecting the long line to be lying in the left innominate, like coming from the left subclavian, going through the left innominate. And then if it's ideally could be just a few millimeters long, just before the right SVC. And as we can see here from the right side, the right innominate comes to join the left innominate to unite in the right SVC before the cavo-atrial junction. And this is a video from one of the babies. We need to keep very close eye on the catheter tips because it's not usually easy to identify them. Some people with different angles can locate the central catheter tips as here, but we need to make sure that we can see or we can open the view to be able to see the catheter tips. From here, as you can see, it ended up by the distal part of the left innominate just before the superior vena cava, and the right innominate should be coming from there. The previous one, we used the linear probe, but you can use different probes, as I mentioned. Here we used a cardiac probe, the S12 probe, just to locate the central catheter tip just above the aortic arch, and then you can open up the left innominate to see the tip. And the beautiful thing about this loop is you can identify the saline or the fluid coming from the tip of the long lines tip. And I would advise, I'm always advising the trainees that we can even do some like focus, use the focus button just to magnify this image. So to make sure that the fluid is coming from the tip. In terms of the lower limbs long line, we can use different probes. On the left here, we can use, we have used a linear probe with a depth of around 4. As you can see here, the lower limb, using the lower limb, whether the right or left saphenous vein, we need to make sure that the long line is coming from the IVC and the tip is away from the right atrium. We need to make sure that this is the tip by using different probes and seeing the flow coming from it. And when we use a different probe, in this we use a cardiac probe, and we can identify the tip as well, coming from the IVC and away from the right atrium, as you can see. In the UVC, we use different probes as well. So here we use a curvilinear probe, the one we use for the head scans. And I found it really useful probe if you don't have the linear probe to identify the UVC tip, which comes through the ductus venosus, and just to make sure that it's away from the right atrium as well. In terms of the UAC, as I mentioned in the long line, here when we use a curvilinear probe to see the UAC, you can see the tip. You need to make sure that to focus on the tip. So in this slide, we identify the T12 by the celiac and mesenteric arteries of the descending aorta, and we take this as a T12 marker. And then if we counted the level of the UAC, here's the UAC, as you can appreciate, it's a bit long. So we need to make sure that we don't identify as this is the tip, because if you follow that line, you can see the tip actually a bit longer, which is a deep around T4 or T5 position. So that line was adjusted by pulling it out here. And you can see here the line is in a correct position below T6. The beautiful thing about the curvilinear probe here is sometimes we got that annoying artifact that sometimes can obliterate the tip position, but using the curvilinear probe, if you want to get rid of this artifact when you see it by the linear probe, you can use the curvilinear probe just to identify the tip and making sure it's not deep. So coming to the first case, that was a 27 plus 4 weeks baby. IUGR, birth weight was 510 grams. There was no risk factors for infection. Umbilical lines were inserted, and the baby started feeding at day 1 of life. There was no problem in the first few days of life. By day 3, there was feeding intolerance and abdominal distension, so the baby was not clinically well and not tolerating feed. So we halted the feeding for some time. At day 5, due to ongoing sepsis concerns, umbilical lines were removed and long line was inserted via the left cubital fossa. So when we did the POCUS initially, if you look here on the right side, we kept we used the linear probe. We have used the depth of around nearly 2.5, and we identified the long line tip there. But the problem here is that operator, one of the trainees who inserted the line, she felt that the line is not advancing more. At the same time, by using POCUS here before fixing the line, we couldn't see like a flow coming when we push some lines through the long line. We couldn't see it here, and there was a bit of resistance as well to the movement of the line. I went through the decreasing the depth just to focus on the long line. Here, this is the tip that you can see. Well, is that the tip or not? Some people might think this is a tip because you can argue that there is some fluid coming from here, but just as most of you might know that even without the long line, and if you got this view, you can still see the flow of the blood or any infused fluid, even from a peripheral cannula. You can see it coming from here. So we need really to see it coming from the tip. My suspicion here that the line wasn't in a good position is when we try to push it down, because it lies here in this left subclavian, and then I wanted to see it coming ideally to the left innominate before the SVC. So the line wasn't moving by the operator, and also there was no flow back of the blood, which I believe it's an important sign. It's not always happening, but it's usually a relieving sign when you get some blood by flowing back. So the next step was just to get more views. So I used again another linear probe, and I can see that the long line is here, but there is nothing in there, and I couldn't see the flow coming from the line. Again here, like increasing the length, the depth of the probe, still it can't identify something which might be the tip, might not be the tip, but I wasn't reassured 100%. I used another probe, which is a cardiac probe, and again, here, using the other probe, you can see something which looks like the tip, but maybe it's not the one, because there is no flow back and there is resistance of moving the line. Changing, as you know, that when we are doing the POCUS, in order to see the line in the whole length, all the waves needs to come perpendicular to the line, so you can see it in length. Now changing the angle of the probe itself while keeping it at the same position. Here we could appreciate that initially there are two lines. Like you can see the line from here, and then if you keep an eye, you can see part of the line is there. So you don't know really what is happening. The baby was kept immobile, like the baby wasn't moving the limb. So there is no explanation why the line is here until we changed the probe position, and finally we can identify that the line has moved like here until the distal part of the left innominate, but it didn't go through the superior vena cava. It just kinked on itself, and it goes back. And from this view, we knew what is happening via the POCUS. Just for safety reasons, I was interested to know in the X-ray and exactly what we were expecting, that the line goes this way, and before going to the superior vena cava, it coiled on itself and it goes back under the clavicle again. So we pull this line under POCUS, and as you can see now, if you focus on the tip, you can see that the fluid is clearly coming from the tip, and the line was pulled back by 4 centimeters, and it's left in a very good position there. And the final X-ray, it showed that the line is a distal part of subclavian vein, as you can see here. So the learning points from this case was that the long line tip is not always easy to identify. So we are not, in our practice, we are not judging the long line from the first time we see. We need to use different probes and using different angles. If the long line tip stays short at the level of the innominate vein despite of pushing, that is highly suspicious, because normally if it's short and you ask the operator to push it slightly under vision, it should be moving. Always make sure that the baby is not crying and unsettled, because if the baby is moving or crying, that might give you false impressions about the length of the line and make it more difficult to identify the tip. Using different probes, we found it in our practice very useful. We are not only using one probe, we are using different probes to identify the tip position. The bubble test, I found it really useful. When we use a focus or reducing the depth, you can identify these bubbles coming when you are pushing the saline. always stick to the distance you have measured. Like for example, in this case, the initial measurement was around 7 centimeter, but if we are pushing it, the operator is trying to push it by 11 centimeters, that's probably too much. And it needs to be around the 7 centimeters, so we are not expecting to find it very deep line. So it will make the mission easier for the person who's doing the POCUS to identify the tip, rather than to go further down to check where is the tip and then pulling it back. Use different angles of the probe to make sure that the line is not flipped on itself. So that was the first case. The second case was again a preterm baby, this time 25 plus 5 weeks. Birth weight is 691 grams. This baby wasn't needing ventilation after birth, was stable on the vapotherm at 6 liters in low amount of oxygen after birth, had central lines inserted, UAC and UVC for parenteral nutrition. Central line tips were checked by one of our trainees. So we are in our hospital, we are encouraging our trainees to do the central line tips identification, but they need to show to one of the POCUS team before fixating it. So the UVC was, this is a picture which, or the scan which was done by the trainee. So it's different one from the operator, from the one who inserted the long line. So the operator here was happy with the central catheter tip. So this is the UAC and this is the aorta, and as you can see, the branches of the aorta, which is a landmark of around T12, and um, um, she thought that this is the tip. So as I reflected in the other case, that we always use different probes. The main reason, especially with the UAC and UVC, you can always get this artifact, which is really annoying, and sometimes it can give you an impression that nothing is further down, and you can just say, this is the tip, and I'm happy with it. But that is not always the case. And the UVC in the same baby done by the trainee who did the POCUS, you can see these two parallel lines coming from the ductus venosus, and here, if you can focus on the right atrium, you can see that, well, it's not really there or just going through it, but it's away from the interatrial septum and definitely away from the left atrium, which is here. So I have used the curvilinear probe, which I personally like in the cases of the UVC and UEC. And if you can see that the long line, the UVC was actually long, going through the ductus venosus, through the right atrium, crossing the PFO, and you can identify the tip in the distal part of the left atrium here. And also, when you use the linear probe as well, you can confirm this finding. So you can see the ductus venosus here, and then the IVC, while the ductus venosus and the central line UVC coming through it, and passing through the right atrium and passing through the left atrium as well. And if we change the probe a little bit, this is also a nice view to show that the UVC is deep coming into the left atrium. At the same loop, you can identify that the UAC also is deep and going to the deep in the aorta near the branches. So the UAC was pulled back by 3 centimeters, and this is a linear probe with a depth of 3, and we can identify here the tip in the aorta after pulling it by 3 centimeters. And if we counted here, it's nearly at T9 level. And also the UVC was pulled back, so it was pulled back. This is during the process of pulling back. You can see it's now not anymore in the left atrium, it's still in the right atrium, and the operator was pulling it back. So it started by here, and we found it when it was pulled away from the left atrium, it's here. Unfortunately, the UVC in this case was overpulled, and we had a learning point from this, because the UVC was 2 centimeters deep, and when I asked the operator to pull it back by 2 centimeters, we believe that it was overpulled, and we are able to track it here up to the very high level in the ductus venosus. So the learning points from this case is, while using different probes could be very useful if you are not sure about the central catheter tips. Always we are encouraging our trainees to use different probes. In the last case, we have used a curvilinear probe and the linear probe, which are very good. You can still use a cardiac probe as well. After measuring the distance for adjustment, do it gradually to avoid overpulling. And this is exactly what I learned from this case, is when, for example, you want to pull any line, not necessarily the UVC, but if even long line, if you need to pull back by 3 centimeters, it's better to do it centimeter by centimeter, rather than to do the 3 centimeters, which in most of the cases can end up by having a short line. Coming to the third case, again, this is a preterm baby. This one is very interesting one, because it was a new learning point for me. This is a 27-weeker baby who needed a long line for TPN. Long line was inserted in the left cephalic vein. The intended distance was 13 centimeters from the insertion site, but actually the operator has inserted it at the level of 14.5 centimeters, so 1.5 centimeters bit deep. I know that most of people, or some of the people, might think maybe we can give it more, 1 or 1.5 centimeter, because it's always easy to pull back rather than to push, and also from the infection point of view. So that line was done by 1.5 centimeter more, and the operator mentioned that there was no backflow while trying to aspirate via syringe. As I said, in our experience, like having a backflow, whether it's too French or less, it's a useful sign. But there was no, in this case, any backflow, and the focus was done to identify the tip for this case. So here I have used the cardiac probe, the S12, and as you can see the tip here. We were not pushing saline at this stage, but here you can't see any like flow coming from there anyways. This is the right pulmonary artery and the aorta, and then if you open up the vessel just above the ascending arch of the aorta, you can identify the left innominate or the superior vena cava if you open this part. So I was quite sure that that was the tip of the line, but the problem here that the operator can't pull even the line back. Like I asked her to try to move the line just to make sure this is the tip, but she was not able to pull that line out. It was stuck somewhere, and also there was no backflow. So in this case, we have done an X-ray, and if you can see the X-ray, the long line tip is in here. Sorry, it's not very obvious, or it's not very clear here in this X-ray, but the tip was here, was in this position, which is absolutely acceptable, and you can use it, and that confirms what I have found with the POCUS. But that was a mystery, because if the line is here, so why not you can't push any saline in, and why not you can't move the line pushing in, or even having a backflow. So when you just follow up the line here, you can see that there are no any kinks, it's not coiled anywhere, but this part was not very clear. So that's why we have repeated the X-ray and the rest, and we have nearly knew what is the reason of that. So as you can see that the long line has gone this way kinked on itself back and then going up there. So there was a kink here somewhere at the left wrist joint. So we try to manipulate, we try to do some massaging, but nothing didn't really work. This long line was a very precious long line because this baby has a nightmare to get lines in. While we can see that the tip in a good position, we feel that it's really shame to use this line. So we contacted the surgical team, and one of the surgical team came, and it was really a matter of seconds to release this knot by I'll try to make a diagram here. So this is a distal part of the line. It goes up, then down, kinked on itself, and goes up. It was really difficult to release this part. So the surgeon just put one of the fingers here firmly to press the distal part of the line while doing massaging from at number 2 here at the distal, sorry, the proximal part, and asked a second person just to pull the line out from here. And it was in nearly seconds then this line was released, and the line worked very well after that. So the reflection about this case that we need to always stick to the measured distance for central catheter insertion. So if the measurement is 10 centimeters, it's better to be around 10 centimeters from the insertion site rather than to thread it more into the limb, especially if we are doing that from distal parts, such as the brachiocephalic and hands, long lines. Backflow, I found it really good sign and reassuring sign that the line is not kinked. Even if you confirm the tip with no backflow, restricted line movement, to consider always an X-ray. The way of the knot was released was really brilliant and new to me to know. So our last case today will be about a long line which was inserted in the long saphenous vein. The POCUS was done to confirm the tip. So here, actually, this scan was done by one of our excellent trainees, who is very interested in POCUS. So he used the linear probe with a suitable depth of 4 centimeters, and usually we flip the V shape because our default the V shape, which is a marker. When we use the linear probe, it's by default on the right side, so we flipped it to the left side, just to be anatomically suitable, keeping the heart on the left side. You can see from this beautiful view, you can see that this is a IVC, and this is a ductus venosus, and here's the heart starting with the right atrium. So when this line was done, the leg of the baby was extended, and you can identify the tip here, just the distal part of the IVC away from the heart. However, when in the next slide, when the leg is flexed, you can see that the same long line is just going through the right atrium, nearly by the interatrial septum position, which is slightly deep here. So what happened here that after adjustment, we pulled out under vision the long line, few millimeters under vision, and when the leg is extended, you can see it here, and the position can be beautifully identified in the IVC. And when we flex the leg, as you can see, it moves forward, but it's still in a safe zone away from the right atrium. So, what I personally learned from these cases that I just use this as a summary of the learning points, and generally reflecting our practice and using the POCUS to identify the long line tips or UVC or UEC tips, that we always depend on 2 probes at least. You can sometimes use 3 probes to identify different angles. it's not always easy to identify the central catheter tips. That's why it's better to use different probes, and with each probe we need to make different angles until all the waves comes perpendicular to the plastic line, so we can identify its whole length. Limb flexion or extension doesn't matter, upper limbs or lower limbs can affect the tip's position. So always check the position before fixing. It's highly like if you don't want to flex or extend the limb for infection purpose or for trying to minimize handling of the baby, it's better to do it while the limb is flexed so you can appreciate the maximum length. And sorry, bubble test, I found it really useful. And when we do the focus button or decreasing the depth, that can be useful to identify the tip, and you can see at the same time when someone is flushing saline or dextrose through the line, you can identify the tip. If the distance that the line needs pulling, go gradually rather than the whole distance. And I give example of a couple of these cases that if the intended length is around 10 centimeters, so keep it around 10 centimeters, 10.5 or 11 centimeters, rather than to go to 13 centimeters and then pulling the line back. And always to consider X-ray if unsure about the position, which is still important in some POCUS images when diagnosis or identifying the central catheter tip is uncertain. Thank you very much. I hope that was interesting and you enjoyed it.
And I think Sarah O from Oxford was wondering if you routinely do X-rays for your lines at St. Peter's.
No, we don't do that. So at St. Peter's, we have a dedicated POCUS team made by three consultants who have been practicing that for a long time. We have a single email for these three consultants, and we are trying to be whether on site or off site in the clinic, whenever a long line is inserted, we one of the trainees send an email to the POCUS team, and then one of us will come and do it. Obviously, it will be very difficult to do it overnight because if we are not on site, or if in situations with uncertainty about the central lines, we still do the X-ray, but we are not doing X-rays routinely if we can POCUS.
Great, and we had some nice comments. Thank you for sharing these amazing tips. So Liam Mahoney from St. Michael's in Bristol mentioned that it's great that you're teaching trainees to look at tip positions. Do you have a structured teaching program for PICC lines? And do trainees have to complete a certain number of scans before being signed off?
Yeah, I think it's a brilliant question, and it's one of the things that we really need strongly to consider. At the moment in our unit, we have a structured program for lung ultrasound, and all the trainees have their logbooks with structured training sessions and weekly meetings, and we are having a very structured and solid lung ultrasound program for them. We are aiming to do the same in the central lines. What is happening in the moment that we are encouraging them to do the scans, but again, it depends on the baby. If the baby is not stable, one of the consultants is doing it. But if there is an opportunity for learning, we encourage them to do the lines. We see it with them. But if no one can confirm among the trained consultants that we don't need an X-ray, we do an X-ray.
Fantastic. And in terms of line migration, do you routinely monitor your long lines?
Yeah, thanks for this question, Jean. Yes, we definitely do that every two so we got a list of babies, and we are doing that as a part of our guidelines for all central lines, including UAC and UVC. We do scans every 2 days routinely to make sure that the line is not migrating. And by on the same note, when we found a good amount of central line who have been migrated or pulled back. So it's I think it's very important to consolidate or to emphasize on this information that central lines needs to be followed up. We do that every 2 days.
Okay, fantastic. And then the last two questions were related to scans done by trainees. So you mentioned the review process by 3 of your consultants to look at lines
Yes.
before they're fixed. And then secondly, do your trainees have to have specific cardiac focus or echo training before they start PICC line training?
That not necessary. They don't need to have it because we teach them how to put where to put the probe and which probe it's better to use. We encourage them to use different probes. But as you know, Jean, you already have a cardiac experience, and you know that it doesn't need to always to. Yeah, it's not very complicated procedure, but it's important to have the skill just to identify the line and getting the position. So it's not complicated as the cardiac thing.
Yes. And so I think in general, you know, the technical skill you need for UVCs and lower limb long lines is less than for upper limbs. Would you say, do you recommend that trainees with one type or another?
Yeah, so usually in our practice as well, the trainees are very enthusiastic when a long line is inserted through the lower limbs or UAC or UVC. They encourage each other to go and scan this line, but we found that they might step back from long lines inserted in the upper limbs. I agree with you. It's more challenging and it's not always easy to get the tip from the upper limbs.
Fantastic. I think I really found some of the tips quite useful. For example, the fact that you emphasize using different types of probes to look at the line, looking at the flush test. Do you also use movement to check line tip position?
Not routinely. Sometimes it's useful, I agree, to use. But if from the first instance we can identify the tip by different probes, by different angles, we are happy about the bubble test. Think we are reassured. We don't prefer to move the line unless if there is suspicious, as I presented in a couple of cases. Yeah.
Can I just ask Sherif, it's really interesting that you done X-ray lines because I think that's probably all our objectives at some point. How did you get around it with the rest of the team in terms of kind of medico legally? Do you guys all have to have had a certain amount of training or a logbook with cases? I just worry that, you know, we always in one unit at some point in 10 years, you'd have one extravasation or one line which is causing a tamponade or something. And so do you save all your ultrasounds? And like, how do you go with the kind of process of it being peer reviewed and stuff?
Thank you, Sada, for this question. This is a very important point, of course, to consider. So when we started more than 3 years back, we have decided to get away from the X-ray because we found that, you know, with more practicing focus, we found that, well, we start to come away from doing X-rays on the lungs. The same thing we try to focus when we are doing the long lines or UVC, UAC. So when we started, 2 consultants and myself, we started practicing that. We did peer reviews, which is regularly happening once every week. We go through our scans, we compare that with X-rays. So we had good time, I would say, above a year. We were depending on the X-ray, comparing our work, comparing our lines. And when we were very confident to see that this is the tip, and we have done all the X-rays. We looked through the X-rays on weekly basis and through our scans, and we felt comfortable going with that. We have decided over the last 3 years, to just do it without X-ray. Also, this is one thing, but even if we didn't do the X-ray, we tend to do, if I do the scan on Tuesday, for example, for a UVC, on Thursday, my colleague comes and do the follow-up to check the migration, and they confirm that, and we discuss that by the end of the week in our weekly meeting. Sometimes, as you can see, we don't do an X-ray, but one of our other colleagues can do an X-ray for another reason, like tracheal intubation or abdominal concerns. We tend to look to these X-rays as well to compare our work. So we felt that we are now confident to use only POCUS without the X-ray. So as a practice, we don't change the limb movements, but we are trying to, before fixing the long line, we keep the limb flexed, and then we scan, and then we make sure even after a couple of days when we follow up the tip by POCUS, we make sure that by moving the limb, the tip will not go too deep.
Okay. So just to recap, if it's in the upper limb with a flexed arm, you want it in the distal SVC.
Yes.
And without it going into the right atrium.
Yeah.
For a lower limb long line, you want it in the IVC and not going into the right atrium.
Yes, that's correct.
Great. And after, with careful adjustment of the line, do you sometimes notice it takes a while for the images to adjust? So Sarah was saying she often sees a slight delay of 1 to 2 seconds of the line having been moved. When you pull the line back,
Yes.
Too soon afterwards, it's
yes. I agree with Sarah that really one of the things that we have seen. That's why we need to wait for some time, not to it's not a 100% live image or live video, so we need to wait for some time. I agree with her. Yeah, we have the same thing.
Yeah, and then I think we had some consensus as well from the comments about the fact that people do find it easier to scan lower limb lines than upper limb lines.
Definitely.
And coming back to Karthik's question about aspirating lines, it's actually a BAPM recommendation for lines to be aspirated. So that was a helpful comment in the chat as well.
Yeah.
Okay, so we've answered all of the questions. Did you have any other comments or anything you wanted to add to the presentation at the end?
I just want to, maybe I was thinking why people are not feeling especially the trainees are not feeling very confident doing the upper limbs long line when they compare it to the lower limbs or the UAC, UVC. I think it's about all the position of the probe, because there is some confusion about where to put the probe. We always use a linear probe. We are putting the marker toward the right shoulder or the left shoulder, like this, just under the clavicle, and facing the marker toward the left shoulder or on the right shoulder. But when we do that, we got really good view. So you don't need to get the aortic arch and then open up the innominate vein on top, or SVC, but you can just put the probe just parallel and just below the clavicle and heading toward the shoulder, and then you can see a nice view. It needs some training, but it's not difficult. This is the message that I want to say.
Thank you. For the final comment on the chat, I wonder if Sadaf might have some insights. I think
the comment, which comment is that, Gina? Sorry, is it the comment that says left is heart?
Yeah.
I'm not quite sure I understand what is that. I don't know whether it's in reference to the lung ultrasounds and the UAC. Is that what your understanding is?
Yes.
I mean, to be honest, when I tend to do lung ultrasounds, I focus on the lungs, and anything outside of it, I tend to try and disregard it. It's that annoying thing, right? When you're trying to echo, you get the lungs in front of you, and you're trying to move them away. When you try and get a lung ultrasound, you're getting the heart in the way. And then I think if I see something that's abnormal, then I would change my probe and go and interrogate the UAC. That would tend to be my practice. I haven't particularly paid attention, on the left or the right, or if I see something that's bothering me, I'll go in and then I'll interrogate it with a different probe. And I guess that sounds like something probably that you would do, Sherif, as well. It sounds like you switch probes quite a lot.
Yes, we do. We do
Yeah.
that. Yeah.
We've got recently a new ultrasound machine, which we've ordered because we got the budget for it. So we ordered as many probes as we could. And it's great because, I switch between three or four probes at times. And it's really
Yes.
interesting, isn't it, to see the different quality of image, the different depth, and the different types of information you get from it. Oh gosh, there are more questions coming in. So Kartik has put a comment saying that the left ultrasound images go over the heart. If you carefully look, the UC comes into view or too many times immediately. Thank you for that comment. And then there's a question from Mohammed Bahari, and these are the last two questions we're going to take because I think we have 5 minutes to the end of the webinar. What kind of machine do you use? Is it POCUS focused or is it a fully fledged echo machine? So what do you use, Sherif?
So we use a echo machine.
Okay, what echo machine do you have? Do you know?
So we use Siemens.
Okay, so I guess it just depends on the trust, isn't it? So
Yeah.
I work across Great Ormond Street and UCLH. At Great Ormond Street, we've just acquired a new POCUS machine, which is the G venue. And at UCLH, I would use whatever probes I have access to on an echo machine. We have a GES70. So I guess it just depends. And I think the main message probably is use what you have. Don't wait until you have the funding to get something to start POCUS. You can do POCUS with anything. So
Yeah. And you can use any probes. Yeah, even in lung ultrasound, you can use different probes as well, not necessary to be the linear one.
I think you've showed that really well, isn't it, in your presentation? It's really nice to see the different types of images you get with the different probes. And the last question is from Sarah saying, do you limit your scan time?
This is very important, yes, because we don't always tend to spend too much time, as you know, because of the infection temperature regulations, and as well the aim of using POCUS is as to reduce the radiation, also to reduce the time rather than to wait for the X-ray. So we do a quickest method. So it doesn't make any sense to keep looking for the lines. So that's why we aim in our training to train our staff to have to just do a shadowing period as a very start. And we tend to do the scan very quickly. Usually it takes 2 minutes at the maximum. We don't do more than that. But in some complicated cases, sometimes it's difficult to see the tip. So we might be keeping an eye on the temperature, but we don't tend to spend more than 5 minutes.
Fantastic. Thank you so much, Sherif, for coming to share your practice with us and your insights. It's been really valuable having you here today.
Thank you very much, Jane. Thank you, Sadaf. Thanks, everyone, for listening to the talk.
Thank you for watching. If you enjoyed this, please check out the other webinars on our channel.